Casualty. A patient suddenly comes to you, clutching his chest in pain. He's complaining that the pain is radiating to his left upper lip. He's feeling sweaty and breathless. The senior doctor there asks you to order an investigation to rule out certain cardiac causes. What would the investigation most likely be? It's an ECG. Hi, I'm Dr. Nandita, and in this module, I'm going to teach you about the basics of an ECG. So in this diagram, you can see the ECG graph. This is the normal ECG graph. You can see certain boxes, big boxes, small boxes. You can see certain waves and intervals. So I'll tell you about what all this represents. So the first wave that you see in this ECG graph is the P wave. Then you have the QRS complex. Then you have the T wave. And sometimes, very rarely, you can see a U wave also. U wave can be seen in abnormal conditions also. Okay, we'll discuss that later on. So and we can see two intervals also, PR interval and QT interval, and we have an important ST segment also in an ECG. So these are the basics that you need to know. What all does these waves and intervals represent? So in the cardiac cycle, the first process that occurs is SA node depolarization. From the SA node, atria get depolarized, then AV node, bundle of His gets depolarized, then the ventricles get depolarized. So, and whatever gets depolarized later on gets repolarized also. So SA node depolarization, that is not represented in an ECG. The first process, that is atrial depolarization, is represented in an ECG, and that is by the P wave. Okay, SA node depolarization is not seen in the ECG graph. P wave represents atrial depolarization. So this is the P wave and it represents atrial depolarization. Next we have the QRS complex. What does QRS complex represent? It represents ventricular depolarization. So QRS complex contains the R wave also. Before that we have a PR interval. PR interval represents process occurring before ventricular depolarization, that is AV node and bundle of His depolarization. Then we have the ST segment and the T wave together. They represent ventricular repolarization. Okay, so these are the processes. P wave representing atrial depolarization, PR interval representing AV node and bundle of His depolarization, QRS complex representing ventricular depolarization, ST segment and T wave together representing ventricular repolarization. Ventricular repolarization is the last process. Sometimes there is a process of late repolarization of papillary muscles that is represented by the U wave. Okay, it's just a fact. I'm just explaining, not that important. Just for a fact, I'm explaining it. And U wave can be seen in certain abnormal conditions like hypokalemia also. Okay, just keep that in mind. Next, we'll talk about these boxes that we are seeing in this ECG graph. So you can see large boxes and you can see smaller boxes inside these large boxes. So each of this large box that you are seeing in this graph is of the dimensions of 5 into 5 millimeter. Large box is of the dimensions of 5 into 5 millimeter. Each of this large box contains smaller boxes, 25 smaller boxes. So each of this large box of 5 into 5 millimeter is divided into 25 smaller boxes. And these smallest box, that is smallest box that you are seeing in this ECG, it is of the dimension of 1 into 1 millimeter. So smallest box in an ECG is of the dimension of 1 into 1 millimeter. The length of an ECG represents time. The height represents current in voltage. So what does the speed of an ECG paper? The speed in an ECG paper is 25 millimeter per second. So in 1 second, 25 millimeter or 25 small boxes are covered. That is the speed of an ECG machine. Okay, the calibration speed. So what does 1 millimeter represent? How many seconds? While calculating that, you get 0.04 second. So 1 millimeter is equal to 0.04 second. That is the smallest box in an ECG. It represents, the length of that small box represents 0.04 second. Okay, this is very useful in the calculation of heart rate and everything. Then the height, I told you, represents current in voltage. So in that, 10 millimeter height in an ECG graph represents 1 millivolt of electric current. So you can see 1 millivolt here, and this 1 millivolt is represented by 10 small boxes or 10 millimeter. When you count this, This is equal to 10. Okay, 10 small boxes represent 1 millivolt of electric current. So this is about the height and the length in an ECG paper, about the boxes and the components of an ECG graph. Next, we will come into the calculation of heart rate from an ECG. So we have certain formulas for calculating heart rate from an ECG. First scenario is when the rhythm is regular. So when the rhythm is regular, we have two formulas. For that, we should identify RR interval. So what is RR interval? This is an R wave, this is an R wave. The distance between two R waves, these R waves, this is called an RR interval. We can take the RR interval according to the number of the big squares that I told you before, according to the number of big squares, or you can take the distance RR interval as the number of smaller squares. Okay. According to that, we have two different formulas. So if you are counting the number of big squares between two R waves or between two QRS complexes, you should use this formula, that is 300 divided by number of large squares between two R waves or between two QRS complexes. So in this example, you can see between two R waves, you can see 4 big squares, 1, 2, 3, 4, right? Almost 4. So we can use the formula 300 divided by 4, which gives 75 beats per minute. Okay. If you're counting the number of smaller boxes, when you're counting the number of smaller boxes between two R waves, you will use the formula 1500 divided by number of small boxes, the smallest boxes. Okay. So when you're taking these small boxes, you will use the formula 1500 divided by number of smaller boxes. So that's it. Example, if you see an R wave here and an R wave here, this is just one large box. So when you take first formula, it will be 300 divided by 1. That is 300. It's a very high heart rate. Okay, 300 beats per minute. But when you take the number of smaller boxes, 1, 2, 3, 4, 5. There are 5 smaller boxes, so you will use the formula 1500 divided by 5, which also gives 300. So that is 300 beats per minute. It's not a normal condition. I just gave you an example to understand. Okay, that's it about the calculation of heart rate when the rhythm is regular. What happens when the rhythm is irregular? In certain conditions like atrial fibrillation or certain kind of arrhythmias, the rhythm is irregular. So what do? In that, you should count the number of QRS complexes over 30 big squares and you should multiply it by 10. So 30 big squares is actually equal to 6 seconds. Okay, from that formula, like one small square equal to 0.04 seconds, you can derive like 30 big squares is equal to 6 seconds. Okay, and when we multiply it by 10, what do we get? We get 60 seconds, and we are counting the number of heartbeats in 60 seconds, which is same as heart rate. So when the rhythm is irregular, we can't use the formulas I told before. So you should count the number of QRS complexes over 30 big squares and multiply it by 10. So when we are taking 30 large squares here, we are counting, we can count like 1, 2, 3, 4, 5, 6, 7. We have 7 QRS complexes in 30 big squares. We should multiply it by 10 and we will get the answer as 70 beats per minute. Okay, so this is the calculation of heart rate when the rhythm is irregular. So here the rhythm is irregular because this RR interval and this second RR interval are not the same. It's different. It's like it's an atrial fibrillation rhythm. So you will use this formula for the calculation of heart rate. So we have dealt about the basic ECG, what the waves represent, what the intervals represent, and the calculation of heart rate. Discuss certain abnormal waves that you can get in ECG. First, let's talk about P pulmonale and P mitral. What is P pulmonale? In conditions like COPD, when the patient has core pulmonale, the height of the P wave increases. This indicates right atrial hypertrophy. So the P wave becomes tall and it becomes pointed also. This is known as P pulmonale. This is seen in case of right atrial hypertrophy. What is P mitral? P mitral is the condition where the width of the P wave increases. So this is the P mitral. And here you can see the width of the P wave has increased, and we can see two peaks in the P wave. This is called a bifid P wave. This is seen in which condition? This is seen in cases of left atrial hypertrophy. Okay. So this is about P pulmonale and P mitral. P pulmonale is seen in right atrial hypertrophy, which is a tall P wave and pointed P wave. P mitral is seen in left atrial hypertrophy, which is a bifid P wave. Sometimes we can get pseudo P pulmonale, a falsely seen increase in height of P wave. It is seen in cases of hypokalemia. Okay. Next is the Osborn wave. This is the Osborn wave. This is seen in cases of hypothermia. So in hypothermia, this an extra wave can be seen. This is known as the Osborn wave. It is usually seen at the J point. J point is the junction between the... So this is the Osborn wave. It is seen in cases of hypothermia. This is that extra wave seen in cases of hypothermia. Next is the delta wave. Where is delta wave seen? It is seen in a special condition called WPW syndrome, which is Wolff-Parkinson-White syndrome. In this syndrome, there is an extra pathway known as the bundle of Kent. So ventricle, instead of getting depolarized through the normal pathway, ventricle undergoes an early depolarization through an accessory pathway called the bundle of Kent. So that happens in WPW syndrome. So what happens when that early depolarization occurs? The QRS complex starts early. So this is the WPW syndrome, and when the QRS complex starts early, we will get this wave known as the delta wave. So it's a small curved kind of a wave that is seen in the ECG because the ventricle gets depolarized early. After a little time, the normal depolarization occurs. So you can see the normal QRS complex here. So this extra wave, delta wave, appears like a small slope. And because of ventricle getting depolarized early, we will have a shortened PR interval in WPW syndrome. So you can see a shortened PR interval, you can see this delta wave, and because of this delta wave, the QRS complex will be a little bit wider also. So this is what happens in WPW syndrome. It's a very important topic. And in WPW syndrome, what will be the drug of choice? It is flecainide. Then the treatment of choice is radiofrequency ablation. So using a catheter, we will ablate that accessory pathway. So this is the delta wave. Next we have something known as epsilon wave. This is seen in a condition known as ARVD. What is ARVD? It is arrhythmogenic right ventricular dysplasia. So this is the epsilon wave seen in arrhythmogenic right ventricular dysplasia. This is a topic which is very important for INI-CET. And this will be the ECG finding in ARVD. We can see that epsilon wave, and you can see an inverted T wave also. Okay, so this there is a chance that this ECG can be given, and the condition, you can be asked to identify the condition. So epsilon wave and Osborn wave looks certain, like little bit similar, but from the history you can like identify, and there are differences between the two waves. If you look closely, you can see the main differences. Okay, so that's it about certain abnormal waves in ECG. And in this ARVD, we have a syndrome called Naxos syndrome, which is a possible INI-CET question. So what happens in Naxos syndrome? In Naxos syndrome, we have a combination of, one is ARVD, another one, patient will have woolly hair, and the patient will have palmoplantar keratoderma. So this combination of findings is seen in a syndrome called Naxos syndrome. And ARVD, woolly hair, and palmoplantar keratoderma. Then let's talk about axis deviations in an ECG. So axis deviations, we have mainly 4 types of axis deviations. I'm not going into the core concepts or the basics. I'm just telling you, I will just tell you the tricks to identify what kind of axis deviation you have in an ECG. So we follow a rule known as the thumb rule. For identifying axis deviation, we take 2 leads, that is lead 1 and lead AVF. Okay, if lead 1 is positive and lead AVF is also positive, this is normal. This is called normal axis. When lead 1 is positive, Lead AVF is negative. These are leaving, okay, leaving away, going away from each other or leaving each other. So this is left axis deviation. Leaving equal to left, L for L. So when lead 1 is positive, lead AVF is negative, it is left axis deviation. Third scenario, when lead 1 is negative and lead AVF is positive, these are reaching towards each other. Reaching R for right axis deviation. So lead 1 is negative, lead AVF is positive, these are reaching towards each other. This is right axis deviation. Then complete opposite of normal scenario, lead 1 is negative, lead AVF is negative. This is extreme axis deviation. So these 4 axis deviations you have to memorize. Lead 1 positive, lead AVF positive, this is normal. When it is reaching towards each other, it is right axis deviation. Lead 1 is negative, lead AVF is positive. When it is leaving each other, lead 1 is positive, lead AVF is negative, it is left axis deviation. And complete opposite of normal, both are negative. This is extreme axis deviation. So that's it about axis deviations in an ECG. Now we'll move into the topic of bundle branch blocks. We have 2 types of bundle branch block, left bundle branch block and right bundle branch block. To identify whether it is a right bundle branch block or left bundle branch block, we have 2 formulas. One is Marrow and one is William. So in this diagram, you can see right bundle branch block. For right bundle branch block, we have the trick of Marrow. So we should take the leads V1 and V6. If the ECG pattern in V1 has an M shape and in V6 it has kind of a W shape, then it is Marrow and it comes under right bundle branch block. So you can see the M pattern in V1 and the almost W kind of pattern in V6. So it is Marrow, so it is right bundle branch block. Then comes left bundle branch block. There we use the formula William. So in left bundle branch block, you can see this W pattern in V1 and you can see this M pattern clearly in V6. So this is William and this is left bundle branch block. Just note that the leads that you should look for to identify right and left bundle branch blocks include V1 and V6. Okay. Next, I'm going to discuss about how to diagnose whether the patient has left ventricular hypertrophy. For that, we have several types of formulas. The most important thing that I am going to discuss is Sokolov-Lyon criteria. In this, we should take the leads again V1 and V6. We can take V5 also, V5 or V6 and V1. To calculate if the patient has left ventricular hypertrophy, we should take the S wave in V1, that is that negative wave, S wave in V1. And we should take R wave in V5 or V6 and we should add these two together. Okay, we should count the number of boxes. If the number of boxes is more than 7, that is the large boxes, if it is more than 7, then the patient has left ventricular hypertrophy. Or in millimeter, when we explain, one large box is how many millimeter? 5 millimeter. So 7 large boxes, 35 millimeter. So if the total sum is more than 35 millimeter also, then the patient has left ventricular hypertrophy. So S wave in V1 plus R wave in V5 or V6, when it is more than 7 large boxes or when it is more than 35 millimeter, then the patient has left ventricular hypertrophy. Similarly, for right ventricular hypertrophy, we should just take the R wave in V1. If the R wave in V1 is more than 7 millimeter, then the patient has right ventricular hypertrophy. R wave in V1 is the positive wave. If the positive R wave in V1 is more than 7 millimeter, then the patient has right ventricular hypertrophy. So this is about left ventricular hypertrophy, right ventricular hypertrophy. Now I'll talk a little on the topic of ECG leads. We have a total of 12 ECG leads. We have 6 limb leads and 6 chest leads. The limb leads include lead 1, lead 2, lead 3, AVR, AVL and AVF. And the chest leads are numbered from V1 to V6. So look at this diagram. As you can see, the direction of lead 1 is from right upper arm to left upper arm. the direction is from negative to positive. Right upper arm is taken as negative. So direction of lead 1 is from right upper arm to left upper arm. The direction of lead 2 is from right upper arm to left lower limb. And the direction of lead 3 is from left upper arm to left lower limb. I am just going superficially through these topics just for a crisp understanding. So lead 1 you saw the direction, lead 2 you saw the direction, lead 3 also you saw the direction. So together these three leads are making a triangle. This triangle is known as the Einthoven's triangle. And we have an Einthoven's law also, wherein lead 2 is equal to lead 1 plus lead 3. So that is the Einthoven's law. This is an equation. Lead 2 is equal to lead 1 plus lead 3. Then the other three limb leads are AVR, AVL and AVF. You can see that AVF is perpendicular to lead 1, AVR is perpendicular to lead 3 and AVL is perpendicular to lead 2. So these rest of these limb leads are also perpendicular to the corresponding other limb leads. And the chest leads, they are numbered from V1 to V6. So V1 is on the right side and rest of the chest leads, that is V2 to V6, they are on the left side. Sometimes we have V7, V8 also, which we place behind to diagnose posterior wall MI. So that's it about ECG leads superficially. Now let's go into some normal ranges in an ECG. I talked about the waves and intervals in an ECG, and let's see what the normal values of these waves and intervals are. So first is the P wave. So what is the normal value of the P wave? P wave should be less than 0.12 seconds. So normal value of P wave, it should be less than 0.12 seconds. So this is the normal value of P wave. Next comes PR interval. So in this diagram you can see the PR interval. The normal value of PR interval is 0.12 to 0.20 seconds. That is the normal value of PR interval. There was a previous year NEET question in 2024 where they gave the PR interval of a person during a normal regular checkup, health checkup, to be 0.21, and they asked what is the diagnosis. They gave normal as one of the options. They gave first degree heart block as one of the options. Answer is first degree heart block. Whenever the PR interval is more than 0.20 seconds, you take it as first degree heart block, or it's a prolonged, you take it as a prolonged PR interval. It's abnormal, especially for competitive exams. So you should know the PR interval, normal PR interval. And with the normal PR interval, we are like diagnosing the, if the PR interval is prolonged, we are diagnosing it as first degree heart block. Next comes the QRS complex. So normal QRS complex should actually be, no need to study the range, just study the maximum value. It should be less than or equal to 0.1 seconds. Whenever the QRS complex is more than 0.1 second, then it becomes a wide QRS complex. Okay. Then the QT interval is important. The normal QT interval should be less than 0.44 second, that is 440 millisecond. Just study that value. Whenever the QT interval is more than 440 millisecond, we take it as prolonged QT interval, and this can be a cause for many kinds of arrhythmias, which we will study later on. So these normal values you should definitely study. One, you should study the normal value of P wave, which is less than 0.12 second. Then the PR interval 0.12 to 0.20 second. QRS complex less than 0.1 second, and QT interval should be less than or equal to 440 milliseconds. So these are some normal values that you should know. Next, let's move into the topic of heart blocks. So next we shall move into the topic of heart blocks on an ECG. How to identify what kind of heart block are you seeing with that given ECG. So there are three types of heart blocks: first degree AV block, second degree AV block and third degree AV block. First degree AV block, what happens is that there is a prolonged PR interval. As I told before, the normal PR interval is 0.12 to 0.20 seconds. Whenever the PR interval is more than 0.20 second, it is called a prolonged PR interval, and that is seen in first degree AV block. So in this diagram you can see first degree AV block. When you observe the PR interval here, it will be more than 0.20 second. So how to identify 0.20 second? I told you like one small box is 0.04 second. Okay, so 5 small boxes will be 0.20 seconds. So whenever this PR interval, that is PR interval is counted from the beginning of P wave to the beginning of the QRS complex. So whenever the PR interval is more than 5 small boxes, it is a prolonged PR interval. That is a trick. So whenever the PR interval is more than 5 small boxes, it is called a prolonged PR interval. Okay, that is the first degree AV block, prolonged PR interval. In second degree AV block, there are two types, Mobitz type 1 and Mobitz type 2. In second degree AV block, Mobitz type 1, it is also called Wenckebach's phenomenon. In that, the PR interval keeps on changing. So, in this diagram, you can see that the first PR interval is short, then it is prolonged, then it is again prolonged, and finally, you are not seeing a QRS complex here. So there will be missed QRS complexes in the ECG in a Mobitz type 1. The PR interval keeps on prolonging until a missed beat occurs. So the rhythm is irregular in this. You can see this RR interval here and this RR interval here, they are not of the same duration. So there is an irregular rhythm. PR interval keeps on prolonging, and finally you will find a missed beat, that is Mobitz type 1. In Mobitz type 2, the PR interval is fixed. This PR interval and this PR interval and this PR interval are also same, but you are seeing a missed QRS beat. So here also rhythm is irregular. This RR interval are different. So but PR interval is like fixed. But anyway, you are seeing a missed beat. That is Mobitz type 2. How to differentiate between Mobitz type 1 and type 2? Type 1 PR interval keeps on prolonging. First degree AV block, PR interval is prolonged, but everywhere the PR interval is the same. There is a regular rhythm. Only thing is that PR interval is prolonged. It is more than 5 small boxes. Second degree AV block, PR interval keeps on prolonging until a missed beat occurs. Second degree AV block, Mobitz 2, PR interval is fixed, it is not prolonging, but anyway missed beat occurs. There is a separate condition known as second degree AV block, 2:1 block. Okay, 2:1 block is a phenomenon that is, we discuss it to be separate from the Mobitz types. In this, first there is a PR interval followed by a QRS, then P wave is not followed by a QRS, again P wave followed by QRS is there. Then P wave is not followed by QRS. So for one P wave, one QRS is there. For the next P wave, QRS will be absent. So it happens in a regular pattern. This is known as a 2:1 block. This can be a possible INI-CET question. So this ECG can be given to you wherein you find one P wave followed by a QRS, next P wave not followed by a QRS, then the next P wave followed by QRS, next P wave not followed by QRS. This is known as second degree AV block, 2:1 block. Okay, this is the 2:1 block. So for two P waves, there is only one QRS. That is meant by 2:1 block. Two P waves, there is only one QRS. So that's it about first degree, second degree. Coming to third degree AV block with junctional escape. So what happens in third degree AV block? There is no relation between the P wave and QRS. PP interval, P wave is here, one P wave is here, next P wave is here, next P wave is here. These PP intervals that you see, they are regular. RR intervals, one R wave, second R wave, third R wave. RR intervals are also regular. But when you take the interval between this R wave and this P wave and this R wave, or this P wave and this R wave, it's different. So there is no relation between the P wave and the R wave. Only thing is that PP interval is regular, RR interval is also regular, but there is no relationship between the P wave and the R wave. So this P wave occurs before this R wave, this P wave occurs after this R wave, this P wave slightly before this R wave, this P wave is after this R wave. There is no relation, right? So that is known as third degree AV block with junctional escape. So there is an AV dissociation occurring. So this ECG can be given to you. You will find the RR interval to be regular, but the distance between R wave and P wave keeps on changing. So there is no relationship. So you should identify it as a third degree AV block. So that's it about heart blocks. First degree AV block, second degree, third degree. First degree prolonged PR interval. Second degree PR interval keeps on prolonging until a missed QRS occurs. That is Mobitz type 1. Second degree Mobitz type 2, PR interval is fixed, but in between a missed QRS beat occurs. 2:1 block, alternating missed beat is there. That is one P wave followed by QRS, next P wave not followed by QRS. For two P waves, only one QRS is there. Okay. Then third degree AV block, there is no relationship between P wave and QRS. PP interval and RR interval are constant, but there is no relationship between P wave and QRS. Next, coming to another syndrome known as sixth sinus syndrome. So in case of certain old age people, you can see this condition known as sixth sinus syndrome. In this, the SA node is affected. So the patient will have certain areas with tachycardia, certain areas with bradycardia. So that is known as sixth sinus syndrome, a very variable ECG. So the patient will have certain sinus pauses, sinus arrests, junctional escape beats. So basically you will find certain areas of tachycardia, certain areas of bradycardia, certain sinus pauses, very haphazard ECG. This is known as sixth sinus syndrome. It is due to SA node dysfunction in elderly people. I wanted to talk a little about management of heart blocks. So whenever the patient is asymptomatic and stable, there is no need for any medical management or anything. But in case of third degree AV block and second degree AV block, especially Mobitz type 2, you should put a pacemaker. A pacemaker should be planned. Whenever the patient is symptomatic or when the patient is unstable, the drug of choice is atropine. Atropine is given as bolus. That is the first line. Then you can also use dopamine infusion, epinephrine infusion, etc. to increase the heart rate. So that's it about management of heart block.